There we go. I have a little bit of an interesting shoulder post-op case.
Mm-hmm.
And I want to talk about like doing like a shoulder manip if you kind of suspect like a loose body. Or she has a sensation that her shoulder needs to pop. And I find that really interesting. So she is a work comp patient. We started around Thanksgiving last year. Didn't get that much better, but because of COVID, waited to have surgery until about a month ago. And they scoped it, and they found that her bicep tendon had like an old partial tear in it and had scarred into her subscap tendon. And they debrided it, and otherwise her rotator cuff and labrum were like relatively well intact. But her pre-op sensations were almost like labral, where she would like raise and it would clunk and catch. She got like totally inhibited. And then her descent from abduction, kind of same thing, like right around 100 or 120 degrees, she would just get this like terrible pain and like not really even be able to control it on the way down. And I'm not sure that that's really any better yet after surgery. So she's 4 weeks post-op. They ended up doing a tenodesis. And her like abduction range of motion is still extremely painful, active and passive. And she still gets that like catch and clunk. And like almost near full inhibition. So now she can, like when she's doing her range of motion, she just says like, I just feel like it needs to clunk or pop and then I'll be fine. So I'm wondering kind of what your thoughts are on that. And she's been in a sling. She was in a sling full time for 2 weeks with just passive range of motion. And then for the last 2 weeks, she's been wearing her sling out and about. And in the 2 to 6 week range for this doctor, we're working towards active range of motion, but like full passive is allowed. And, you know, with a goal of full active by the end of 6 weeks.
So that's all she had done was the tenodesis? They just did the debridement and then moved the tendon?
Yeah, so her rotator cuff is untouched.
Yeah, just making sure that I kind of know what they actually finished, you know, what the actual finished product was looking like.
Yeah.
You know, it's interesting because when I had my shoulder done decades ago, and my shoulder used to feel like it had to pop, and it actually would. One of the things that I'll sometimes have happen to patients that are post-op, especially ones where they have to enter the joint space. So sorry. If they have like a labral problem, something of that nature, is it actually decompresses the joint, right? So it's an enclosed area that has a certain amount of pressurization to it. When they have to enter the joint to do something like debride a loose body or do some sort of labral repair, it decompresses that, and it takes time for that pressurization to build back up. So doing some traction technique stuff actually works pretty well, because all it does is it expands the volume of the joint and allows the joint to fill better with synovial fluid and, you know, kind of maintain a little bit better tracking. So that does happen, but it's interesting that she was already having that sensation before the surgery.
The sensation of it needing to pop has only been post-op.
Oh, okay. So the other stuff was just clunk. Yeah.
Yeah, and the clunk.
Okay.
And I started in the last week. I tried some distraction with her in supine in the scaption plane, and it was relatively provocative. And I thought even maybe if she's been in the sling, if her humeral head was sitting really far forward. So I tried to do like just with my thumb on the anterior humeral head and my hand on the scapula spine to just do like a tiny posterior glide. and she was actually like much worse after that in terms of like her ability to abduct. So any other ideas?
Well, I mean, if she's only 4 weeks out, because if you're doing this previously, there was a decent chance there was still enough swelling in the capsule that the traction was actually uncomfortable for it. So basically just extra stress on an inflamed tissue. So it could be something that you're basically just biding time for the time being and saying like, well, we got to get this irritation down a little bit first, and then we're going to go back and try this again. Because the other thought would be that she's just getting real poor kind of spin. I guess it's more of that swing with abduction, which would be the problem with that she's having currently. But just the control of where the humeral head rests on the glenoid is probably not real good at the moment. So the idea of trying to figure out ways to help improve that. The one that used to work for me was not so much a straight distraction moment, but it was actually a distraction with an inferior glide. That tended to help quite a bit more than doing, a pure gapping types direction.
Yeah, I tried some inferior glides today. I could only get her into like 70 degrees of abduction before she really like tensed and spasmed up. But I guess that was probably more of a pure inferior glide instead of combining distraction with it. So I can try to kind of combo that next time.
Yeah, I mean, obviously you're going to have to grade things a certain amount just based on her irritability.
Yeah.
And like Dave's kind of writing here on the comments, I mean, some sort of labral impingement is definitely still a possibility with the tracking issue. Where you're getting kind of an impaction of some of that labral tissue, and it could be remnants of what was left of the bicep tendon coming over the superior portion there.
Oh, the loose portion now.
The stump, yeah.
Yeah. Okay. Dave, I'm not sure how to grade it, but I would say mild.
Okay, so I was curious how hard you were pulling with the traction and the angle would dictate it, but my train of thought was
was labrum. Yeah.
Right along with what you said is, you first give me the history without surgery. It's what it sounds like. It's, if you think that losing that suction in the labral injury, feeling of having to pop, or is it sitting off axis in some way, which would do it. And then that's all they find with surgery. My next thought would be, and its biceps tendon adhere to the subscap. Is she still just moving it off axis in the rotation, either due to the subscap or the biceps tendon idea of it being just the resected portion of it causing that? It was a good thought on there too, because there's something still causing her off axis motion. That's where it may be working your shoulder through different ranges as you move it. You can almost look at even like, it's always a good time to work on these skills, is to play with some of the ligamentous and stress tests and get the shoulder in different angles and see, can I move it at different angles? And what do I get? Can I slowly work her up through basically different ovoids and motions, maybe even the shoulder quadrants, and seeing, not binding the quadrant type, but can I use this to just kind of get the shoulder through these different quadrants, and as she gets used to moving it, can I find the pathway? Or is it that this, you're seeing that the subscap, because of the scarring that's occurred, is that in some way bound down and restricting her overhead motion as she goes up into abduction? Because I have that external rotation moment, and my internal rotation and pull this way because my subscap's not able, that firing mechanism may be off, or her more likely her motor patterning is off.
Yeah, it definitely is.
Yeah.
Sorry.
No, go ahead.
She had been managed. I didn't realize this, that her initial prescription came from an urgent care doctor instead of an ortho doctor. So we had to jump through a bunch of hoops to get her to see a shoulder guy, and I had to push a lot for that. And so the urgent care place had, sent her for an MRI. And when the ortho doctor that I like a lot in the area saw it, he's like, it was kind of a crap MRI because it didn't show very much, obviously, because I think the precision of it, or it wasn't as clear of a picture. And I was thinking labrum 2, and they didn't do it with contrast. And so they ended up deciding to do the scope instead of repeating another MRI. And so I was kind of hoping that they were going to find a labral tear, because that would explain, I think, a lot of her symptoms. And I was really surprised that in general, like, labrum looked pretty good, cuff looked pretty good. I think she probably had like a little bit of fraying in her supraspinatus, but her pain is all like posterior corner, which is kind of unusual. Like, I don't know.
Like posterior superior corner, like around the supraspinatus?
Just like, lately when she is especially going into abduction, it's just like here.
Yeah.
And that's like when she'll totally get inhibited, like that's where she grabs it.
Yeah. So the other thing that can be happening in that situation, and this is very much what Dave and I have been talking about, is that if she's experiencing this kind of poor swing motion of the humeral head, there's a decent chance that she's getting some sort of translatory moment with it. The most likely with any of these sort of things that you're describing is going to be something inferior and anterior, where she's just going to have a little touch of laxity. And that's what I was going to mention with Dave talking about checking some of the ligamentous stress tests. Once you can kind of get her into a position well enough to test some of them. Because my guess is you'll find some laxity in one of those components, probably some of the anterior components. And so what that'll end up showing you is that you're getting this sort of motion. And as soon as that starts happening, this back corner here, you're more likely to clip it with those movements. So there's probably some, you don't want to necessarily just call that there's some scarring back there, but there's probably some, hypomobility of some of that kind of connective tissue, whether it's capsular stuff or whether it's some of that posterior ligamentous mechanism, or even some of the cuff tissue that's continuing to force that humeral head into that kind of translatory movement rather than getting a nice smooth spin where it's nice and controlled. So you may have to go through and do some like muscle length testing, which is kind of a pain in the butt to do when somebody that's a post-op. But the odds are that it's going to be some sort of posterior cuff tension if it's going to be muscular. And the capsular stuff you'll just do directional glides right into it. And you can basically just feel for where it feels the most restricted. And then you kind of work into that to see if you can actually release some of it. And if you can, then the pivoting movement that you should be getting there at the humeral head should improve, and you should notice, a hell of a lot better movement there. The other thing I was going to mention, Dave was talking about taking her through various ranges in order to try and do some mobilization on it. The other thing you can do there is take her through put her into some various positions and actually have her contract that subscap. So just have her give you a little internal rotation resistance. Because you may be there is also the possibility that she's getting a little like synovitis type stuff. So it's not scarring between the tissues, but it's scarring between the synovium and the actual tendon. So basically taking her into various ranges and give her that resistance. It's going to take the synovium and the tendon, and it's going to get those two things to move against each other. And so maybe that'll help with some of the clunking and kind of some of that poor mechanical movement as well. Just a couple of ideas that you can try out, I guess.
Yeah.
Yeah, I just posted the same thing. Same line of thought. You're thinking, okay, I got neuromuscular, again, change in pattern there. But, it's hard. You're in a tough zone now because you can't fully assess a lot of, like I said, muscle length would be one. I want to know, okay, where do I have in the capsule? Do I have that, again, as he got that posterior, that anterior, inferior? laxity moment where that gets it off the axis or center of rotation where it should be. And that's where she feels this slipping feeling because she's off her center of axis. What this needs to do as far as, okay, it's gliding inferiorly when it shouldn't be. So now we're off axis. Or if it's tight posteriorly, then that's going to alter the axis. But again, it could be tight posteriorly or it could be shifting posteriorly. And that's creating stress at that point, or the impingement in the back. So you kind of think of, okay, I have an all bets are off scenario, but if I know, okay, what do I have in the capsule? What do I have in the muscular system? You know, if I can find something there, then okay, that's the variable that's causing this posterior, maybe this mild posterior impingement or irritation to occur, because now I see, oh, I'm off axis, or subscapularis is scarred, and if it's scarred, it's going to restrict the motion. That's going to change it. It's going to pull it anterior, and then I do impinge in the back, or start to break down in the back or superior posterior region. So I just kind of go through my list of items, just as Eric described it.
Yeah, and you gotta sometimes think about some of the larger picture. Step back and look at it from a larger view, and not just think about the subscap as kind of that shoulder internal rotator, because you could also look at the lats, which tend to be a big problem. People that are post-op stuff because they're so guarded, pec major, all that sort of stuff, because those are things that you don't tend to get into the movement until you start getting into these ranges out here. But that's stuff that you can work on, without having to actually do too much to the shoulder, because you can do more, soft tissue needling stuff to those sort of muscles that may help to release some of that tone. Because odds are, if that's contributing to what she's feeling now, it's been exacerbated by the, immobilization after the surgery.
Yeah. We've worked a lot on pecs in the past. And even when she's like relaxing supine right now, her shoulder is like she can't, it just doesn't sit symmetrically, which I think makes sense, just because it's been, it's probably almost a whole year now since her actual injury. And so it's just been like a really long road. She has a really complicated history of a lot of other like psychosocial factors too, which I think doesn't help. And her job was like a shopkeeper at an airport, so it was actually a ton of heavy lifting. Thankfully she's retired, so we don't have to get her back to lifting like 70 pounds floor to waist, which is good. We added isometrics today, and her internal rotation isometrics were pretty good, but for her external ones to be like manageable pain, we actually had to get her into like 20 degrees of flexion, because when she was in neutral, her external rotation isometrics were painful. I don't know if that necessarily has any impact on your suggestions, but
that's what I think of. Okay, I have the humeral head, where am I doing? I'm taking it forward, am I taking it lateral? So if I'm at my side and she's slightly forward, my humeral head sit here. Is it shifting forward and down versus I get here? Does it change? So I think of, okay, why do I have pain? And what in the humeral head? Pain, what about that angle? Especially because you got to look at if she's here and it's down. Is it here or is it back here? Now, as you can see, I'm sitting forward. But again, you see the posterior side of it come up. So kind of look at those positions and see, okay, what in there could be a predictor of the pain. There's going to be a bit of a lateral rotation, conjunct lateral rotation as she goes forward, but maybe not enough to impact it or be a variable. So you also have the lateral rotations that can occur with this. And is it because, I don't know, I would think it'd be easier if she was all the way down or hunched, because she's going to be more of an internal rotation. If it was a subscap driven problem, she goes forward and out, I get a conjunct lateral rotation. It would seem to lengthen subscap across that area. That may or may not be a factor.
Yeah. She did well. I ASTENed her posterior cuff today, and that actually helped her active range of motion in flexion and scaption with a lot less pain, and improved probably her end range by like at least 10 degrees each way. So I think we're onto something. Well, if her posterior cuff is so tight that it's shoving her forward, like the neuromuscular input from the ASTEM probably allowed it to like relocate better and limiting that posterior impingement.
Yeah, I
is what
think ASTM is valuable in desensitizing, and especially if you're looking at inhibition versus scar tissue remodeling.
Yeah. So cool. I have a lot of ideas for that. That's good. Thanks.
All right, Tony, you're a man with ideas. What have you got for me on this case?
For this case, I was briefly listening in and out. I was finishing up my last note, but I wasn't sure if we mentioned anything on C-spine, especially in regards to some like subscap pack restrictions. Down the road, I know she's early on post-op, but I'd definitely be looking at a lot of first ring issues as well, especially if we're talking about just humeral head positioning. Addressing issues in there, I think, can play a big role in where she's kind of at rest in regards to keeping that joint centered. So I've done in clinic, I've done a lot of work with first ring and pretty much all my shoulder patients. That seems to clear up a lot of problems too, especially with some overhead control, and even kind of helping recruit cuff a little bit better too. So from everything you guys said, that's probably the only thing that I would add into it.
Yeah, and from there, what's fun to play with is just get a sense of maybe a SC joint in manubrial resting position.
Yeah, absolutely.
It's going to go along with the first ring when treating that, but it's also that sense of, okay, she's been like this for a while, and if she's pulled up this way, you see SC joint pulled up this way forward. Manubrium could be centered, or manubrium could be rotated conjunctly or concurrently with it, or it could be spun the other way. And that's just because she's had this going on for so long. It's just kind of fun seeing these individuals because you can mobilize SC joint and kind of get up into the shoulder a bit. Just get a sense of that. If she's been there for months, it's kind of a fun thing to play with. You have to see what value it gives you.
Mm-hmm.
She's a good one to see where did she end up because of all this shoulder pain. It's there as well. So look at the first ring and second ring and C-spine, like Tony said. That'd be something I just get a sense of as well. Is where does she sit? Because she's had this going on for a while.
Yeah, we've definitely assessed and done some mobs. Her cervical range of motion was pretty limited on her first day, especially with infralateral side bending and rotation. And I'd say that's improved to at least like 80% or 85%. I think she just turned 61. So I wouldn't be surprised if she's starting to get some arthritis in there too. But I don't know that I've gone back and done a lot of C-spine stuff since surgery. So
yeah, I mean, you gotta still think clear and present for the most part when you're doing post-op stuff, because like you can fall into a very easy trap of spending a ton of time like searching out culprits things. Like, I mean, not that the first ring and clavicular stuff and C-spine stuff's not important, but you got to still prioritize. Like, I actually have to spend time working on the shoulder here because that's what the surgery was for. So it can get tough sometimes where you just get that like, oh, I want to go find that keystone problem and start fixing that and change things overnight. But no, I totally agree. I mean, you're going to have to assess that stuff eventually. It's just a question of how much time you need to devote to it. But there's certainly stuff you can do to kind of check those things, because you can move into different muscle groups and such that you may be able to do better resistance testing with. So getting into the forearm, getting into the wrist, all that sort of stuff to start assessing, 5, 6, that sort of thing. See if you can find ways to test out and see if there is some sort of facilitatory quadrants.
That Eric freezing up a little bit?
Yeah, I think so.
So when we're working on her range of motion, I mean, I understand conceptually we're not really at risk of like damaging the surgery, but there's not really, I have been hesitant to really crank on her from a range of motion perspective, especially into abduction, because it is so painful. And it just doesn't seem like it would accomplish very much to me to like force it. And so I just kind of wanted to make sure that that's like, I'm still on the right path with that. Cause what I don't want to do is to send her down into some other crazy, pain cycle, cause that would be counterproductive. So
Think about this, what are the component motions you need for abduction within the shoulder? So I don't ever really think about abduction as being abduction, like I want to get abduction. I think about what do I need all the components to do to get full abduction. And I treat from that point and out. So it's not so much that it's, okay, I need abduction, but again, I need basically intercapsule mobility. I need muscle length. I need motor control. I need a lateral conjunct rotation. I need all these components to get up in there. And if I work on those components, it's sometimes a gentler way to approach it versus, okay, I need 20 more degrees of abduction.
I don't think he intentionally did.
Hello, Chris. Rissa.
Hey, how are you guys?
Hi.
Sorry we're running late.
No problem. Kara had a shoulder patient which had it was a work comp injury, and basically ended up going in and taking a look at the shoulder, and then he found that the biceps tendon had partially torn and scarred at the subscapularis. And they cleaned that up, and then with the patient, she's about 4 weeks post-op. And what they're looking at now is she has a lot of posterior, superior shoulder pain. It's about the same. A lot of pain inhibition with abduction. So we're kind of going over that case and talking about it. And we just kind of progressed on to, how do you progress, the range of motion of abduction with this individual when it's, moderately to severely painful and inhibited.
How much abduction do they have right now? Like how much of a loss?
Actively, without excruciating pain, maybe 60.
Okay.
Flexion is probably 135, and scaption probably 125, with 3 out of 10 pain or less.
What was your active? I'm sorry if we forced to ask that.
Active flexion is about 135. Active scaption is about 125, with not too terrible pain, but discomfort at the end of the range.
Okay.
What was the external rotation? Sorry, give me it again. Did I have subscap repair too?
Yeah, subscap. Was there subscap repair or just a debris?
No, they completed a tenodesis actually, and debrided the rest of, I think, some subscap and some supraspinatus. Her active assisted external rotation was really limited last week, and that's improved a lot with just doing like cane exercises. Now it's probably 50 or 55 degrees when she can use a little bit of external stimulus to get her further into the range.
How many weeks out?
4.
Okay. We were really just talking about this because we do lots of shoulder protocols here. We're kind of learning and working through and communicating where they're at with the surgeon, etc.
What structure do you feel like is limiting her abduction? Do you feel like it's just a symptom of the surgery, or do you feel like I'm going to go on capsular or?
There, I do sense some restriction, but it is, I would say, primarily pain and spasm limiting.
Okay.
Where I don't know that I've really felt, I don't think I've gotten to a true end feel yet with it, because it's clearly so uncomfortable for her that I'm just not really, I don't think it would be productive to jam her into it. So
or what's uncomfortable? Passive range, passive end feel, muscular end feel.
Sorry, can you repeat that?
What's so painful, and where is the pain at?
Okay, so the pain is like posterior superior corner, and she is very painful in passive. So we actually haven't been doing that much lately. I think you guys missed this part, but she has like a really complicated history of like physical and sexual abuse and alcoholism as well. So I think some of the hand holds and being completely relaxed, having her like arm moved for her, I think is really challenging emotionally too. But so when we've been doing just a lot of like cane exercises, and she can get further, but she's still at the end of the range will kind of get like a catch or like a hitch, and then kind of become completely inhibited and just like slump and collapse down. Her shoulder will, not like her whole body.
So if someone's having a lot of pain and they're guarded and they're not wanting a lot of manual contact, there is something I like to do just to get them used to my hands, and something that I don't feel like I'm being very intrusive. The technique that I like to use is called a butterfly PA, where you're up at the you're superior to them, and you're basically like grabbing a hamburger on the front of her shoulder and the back of her shoulder, and then gently lifting, gently coming down, gently lifting. So you're providing a little bit of a PA. We're talking, if you're doing Maitland, 2 plus, 4 minus, just to stimulate the mechanoreceptors.
Is that in sitting? Okay, got it.
I'm just kind of coming through while she's laying on her back and trying to be as gentle as possible. Basically, this shut down with guarding. And I've done that for 2-3 minutes sometimes, just to introduce some manual therapy. I know it's not highly technical, but sometimes that's my way in with those with that patient.
Yeah. I think you probably missed this too. I've been working with her since about Thanksgiving. So okay. I do think that and she waited so long to have surgery because our outpatient surgery was shut down in Chicago for, I don't know, 3 months at least. She does better with direct pressures on the shoulder than she does if I have a hand on her forearm and trying to go like overhead, or like if I've tried to do like a scapular stabilization and overhead stretch for like Terry's muscle groups. I think that is a little bit more of a triggering position for her. So, but I definitely will try that. I tried kind of an isolated posterior glide just with my thumb on the humeral head and my hand wrapped around stabilizing the scapula. What we've discussed kind of up to this point today is we think she's probably getting a little bit of like a posterior impingement. So trying to get her axis of rotation to become a little bit more true by, figuring out exactly where she's tight and probably like pushing her humeral head forward too much. There's one other thing I was going to say.
Do you think that her humeral head is, let's just say, shifted forward a little bit, irritating the structures?
It is.
I will
definitely.
Sometimes, that's one of the few times I will tape with using some Luco tape, maybe even dynamic tape across the front of you might already be doing it, but just providing a little bit of a glide. I thought that might help her with her exercises. I don't use a lot of tape. That's one of the instances that I will, to try and get better certification on the.
Yeah. I'm actually really glad you mentioned that. We taped her a ton before surgery. I actually thought we were going to find a labral tear going into her scope because that's how it behaved pre-op. Her labrum ended up checking out pretty well, but I think now I could protect her incisions well enough to actually get that A, stimulation, and B, a little bit of like support, kind of holding the humeral head back in the glenoid. I'm glad you brought that up because I haven't thought about taping her since she's had surgery.
And I always think about doing minimal force necessary. You know what I mean? I try not to be too aggressive with that. I'm trying to get a little bit goes a long way, so I'm not doing overcorrection or something.
I'm going to call those hamburger mobs.
All right. A butterfly PA is the way I learned.
Oh, okay.
My other thought too is you're still working on, you said flexion passively, she was 125 or 30.
That's active. Yeah,
my other thought too was just take what you can get with, like, if she's going to give you a flexion and scaption, and that's a more tolerable passive range and end field to get, just go with that.
Mm-hmm.
And then eventually, 4 weeks is still pretty early if you get a chronic irritable post-op shoulder, just go, I always kind of go with the path of least resistance. If she's going to give you flexion and scaption and ER, go with that and check it in a week and see if that abduction doesn't calm down.
Mm-hmm.
Maybe 4 weeks is still pretty early in the game for what it sounds like she's got going on.
Mm-hmm. She was really flared up on Friday, and she also is, I think, a little bit of a perfectionist and will probably overdo, like if a little home exercise is good, a lot must be better. And so I just said, like, don't do any PT exercises over the weekend. So relative rest, just because I think we were probably just taking it off too much. And I think it is, like you said, it's important to just step back and be like, she had surgery, kind of traumatic, just like let it calm down a little bit. And, with the pain science that we know now, like you said, go with what we know, kind of solidify those pathways is, the brain understanding that not every signal from their shoulder right now is going to be painful will also be, I think, helpful going forward.
Yeah, that'd be it too, is looking at the axis of rotation of the shoulder joint as she does go into abduction. Is it that the joint is going straight like this, or does she need to spin earlier? Does she need to kind of clear earlier? So in that early going, do I have this or do I have this going on?
Yeah, she has neither of those going on right now.
Yeah. The part of it is just sometimes in the low non-painful range, I always get my hand on the shoulder at a different angle and just work the rotation and just kind of get a sense of, from proprioceptive input, can she get a sense of, I need this lateral rotation? And even it's just kind of working in an early range in any way you want to do. I mean, you can do, resistance, you can do counter resistance, you can do, basically I'll just take my hand, almost guide the shoulder through that rotation. They just feel me pulling on the skin from a tactile standpoint, where maybe inferior glide with the rotation, just to get a sense of, okay, I need to kind of work on that motion to clear as I come up here. Versus once you're in here right away, she's almost right on the tissue and impacting, especially if it's inflamed from surgery.
Yeah.
Getting the same pain you had. The only concerning thing is you're getting the same exact pain you had prior to surgery.
It's not exactly the same,
okay,
and I'm trying not to actually put a lot of words behind that right now, because I don't want her to get stuck on it.
Yes.
And so she'll say, like, I can tell I'm making a lot of progress since the beginning of surgery, or since surgery with range of motion and stuff, but I'm like worried, because here I was hoping that it would resolve this, like, that really bad, like, clunking, completely inhibitory sensation. But it seems like it's still happening, maybe to a slightly lesser extent. But, I'm trying not to get too worried about that either, because she is still so early out.
Yeah.
So.
Yeah, it's true. They could have gotten what caused the motor pattern and that irritation in the back. That's the output from it.
Yeah.
Now they kind of got that. You're right. They get the front kind of cleaned up where it can progress. That's just can you get you moving in that pathway.
Yeah. I feel like my patients have totally taken over our Wednesday session, so I don't want to hog all the discussion.
Patient is a patient, as long as you find it valuable.
Well, I know, but I just want to make sure that we can help other people's patients too. I'm not trying to hijack sessions.
Oh, it's fine. Tony, do you have any specific questions for today?
I got a good patient. I've been working with her a little while now. She's actually an employee of ours, one of our traveling receptionists who helps out. Old thoracic spine injury from about 5 years ago. She used to work as a CNA and was going to transfer a patient, and her coworkers didn't help. It was a heavier set patient. The patient collapsed. So it was kind of like a big flexion load through her thoracic spine. Felt immediate pain. She was living out of state. I can't remember where, but had PT at the time, but it was pretty cookie cutter, straightforward, basic strengthening, stretching, things like that. So she's been dealing with this for a while. Came to see me. She was presenting with like some T4 symptoms, some upper extremity paresthesia, not really specific to segments or anything like that. Breathing, super limited. Rib mobility from like T1 through 8 was just rock hard stiff. So for the first 3 weeks, we worked a lot on rib mobilizations, general thoracic spine mobility, rotations doing a lot better. Breathing's getting better. She still has some stiffness throughout some of the mid-thoracic spine areas. But give me just 1 second, guys. Apologize. All right, sorry about that, guys. Patient emergency scheduling issue. So rotation's getting better. Breathing is slowly getting better. But she still feels just a lot of tension, thoracic spine area, paraspinals, almost intercostals too. But she's also got a lot of weakness as well. If I get her in quadruped, she feels like her right arm is just going to give. So we've been working a lot on kind of like some scapular recruitment, getting serratus, rhomboid working together to help with some of the rhomboid stuff. And then a lot of diaphragmatic breathing retraining too, especially with some rotational movements as well to help with some of the active limitations that she has. So my plan with her this week was, since passively she's getting better, but it's more like active limitations right now, is really to work on some cardiovascular work, because she's been pretty limited over the last 5 years. She is heavier set. Walking's limited, things like that. But also just trying to get her working through these rotational flexion, extension limitations, but more actively. So just kind of want to hear what you guys' thoughts on where that, and anything else in regards to some manual treatment that might be beneficial too.
I'm sorry, what was the age?
She is 32.
Okay.
Interesting.
And vitally restricted through the spine. You know,
I think I cut out what the.
Sorry, what was that?
I think I cut out when you were talking about what her thoracic injury, but I don't remember what happened. I didn't hear what happened.
It was a lift, and it was a big old flexion though. She never said she got formally diagnosed. Like, imaging was pretty insignificant. She's just right now extremely stiff and extremely guarded. She is showing some signs of T4 symptoms that have subsided for the most part, other than some right worse than left upper extremity weakness, especially with grip and anything weight bearing.
Weakness. Okay.
right, stability testing through the spine.
Okay.
How was T4? Was T4? Do you have any shearing?
No, nothing excessive. She at one point, like around T4, 5, she did have she was stuck laterally. Since then has done well. I corrected that. Other than that, it's mainly, for the most part, rib mobility issues more than anything.
And her strength didn't change. Their strength didn't change after you corrected the translation.
Well, and here's the weird thing with her strength. Her strength gets weak over time. If she's riding a lot, she'll feel her grip go. If I test her myotomally, it's actually strong. I can't break her wrist extension. I can, break her shoulders a little bit, but nothing that would make me overly concerned there. So it's goofy and seeing it in clinic. She'll tell me how she struggles with grip and writing and things like that, but it's not necessarily translating to what I would expect to see from like a segmental myotomal exam or anything like that either. Mm-hmm. Gets numbness and tingling in her entire hands some nights, but that's actually gotten better since some of the stuff we worked on too just now happens kind of intermittently.
Yeah. Yeah, I mean, the way she's describing the weakness certainly sounds like it would be fatigable, right?
Right.
So it's a little unusual. The fact that, the myotomal tests don't really come back positive is interesting, but you could be, based on based on the idea of positional things, gripping, lifting, weight bearing, you could be dealing with more of an AXT problem there.
Okay.
So she could be having, transient fatigable weakness, but it's positionally dependent, it's activity dependent.
That makes sense.
It would have to be, some sort of double crush issue. So something maybe cervical, something's, in the clavicular region, something of that nature. But certainly, you'd expect some, upper rib complications from that sort of deal.
Mm-hmm.
That's a tough one. Have you tested like upper limb tension tests on her?
Yeah, pretty negative for the most part too, which is the other goofy thing. She does have some sensitivity along the pathway, which I did work on last time. Like I kind of followed median nerve pathway to try and desensitize it a bit. She did well with it. I see her Friday, so we'll see how she kind of went in throughout the week. But median and ulnar nerve are pretty sensitive on the right, so we worked on kind of like desensitizing that pathway a bit. But tension-wise, she's pretty symmetrical and normal.
Have you looked at TOS?
I'm sorry, what was that?
Have you looked at
TOS? Yeah, that was negative when we looked at it, but that was been early on too. No diminished pulse or anything like that.
Well, sometimes it's just be neurogenic. Sometimes they'll palpate like middle scalenes or pec minor, dig in there, see if it reduces the hand symptoms.
Mm-hmm. Right. So that's something I can easily look at when I see her Friday.
Yeah. I find that if with people who've got that bad of rib hypomobilities, their pec minor will definitely be involved. And I think Dave probably just wrote this on too, but you might not get like a full positive bruise test, but if you could get that, you might be able to get some better shoulder mechanics, and then maybe her rotator cuff wouldn't be, or then maybe her strength could be a little bit better through her cuff as well, if she could just get better scapular positioning.
Mm-hmm. We'll see. And the other thing that's complicated too is I do think she's extremely sensitized. So she texted me late last week saying she sneezed and completely set herself off. So I'm like, oh, maybe she subluxed her rib, pissed it off. So I had her come in the next day, and nothing from like a biomechanical subluxed fault that I found. So I mobed her, and I literally just put her on a vibration plate for 5 to 10 minutes, and she got off and she felt immediately better. So I think a lot of this is like a sensitization problem too that we've been working quite a bit on. So I have thrown some vestibular training into this too, as just kind of to try and ramp down some of the tone that she's dealing with on a daily basis.
I'm kind of in line with Eric in the sense of, at the very least, probably a double crush syndrome somewhere.
Right.
Bilateral hands, that sense of weakness, I'm thinking, you got to get some mild grade compression. You mentioned that she's deconditioned, so she's probably overweight, I'm guessing.
Yep.
And are her wrists rather large? One of the
yeah. Mm-hmm.
Yeah, that's one of the predictors too of it is that, if you have the more rounded, thicker wrist individual gets more carpal tunnel than the thinner wrist individual. So she has that body build. That's one of the things that can set it up. So at the very least, it kind of checking the box of, okay, I got some mild neural compression. Certainly kind of has a thoracic history, so looking at some of the upper thoracic spine, but being 32, probably some weight gain, some other things, she'd be in that category where she has probably that risk for lower. So that hand intrinsic, and that's what it is, you're trying writing many times out, the hand intrinsics tend to fatigue out. If you're seeing the fatigue out in the shoulder with writing, then it's, okay, is her arms out away from her body, or is she down in here and rested? What is the shoulder position? Mm-hmm. One of the things they'll talk about sometimes is obese people getting carpal tunnel when they have office jobs because it flares their shoulders out and their extensors have to work harder versus when they're down and in, you have less extensor tone.
Right.
So is there, that's something that's probably a piece of this in somewhere. So I would look at these as well as in thoracic region. You say you're mobilizing, or how are you mobilizing your thoracic spine?
So we've done some seated work into extension early on, lateral glides. Prone is typically where I'll get it for the rib mobilizations. Okay. We've done some seated traction for some of the kind of more subluxed areas that she had early on. That's gotten a lot better. So right now it's a lot of like grade 4 rib mobilizations at this point.
Okay. One of the ways I mobilize ribs, often it's kind of, if I saw it and you're with me, it's just quick and dirty. Lay them on my hand, like I'm going to mobilize the rib. I can just set the thumb or set the rib right on my thumb, come cross body, take an anterior medial, posterior lateral. And I'll use it as a quick rib mob. And if I find something that's restricted, then I'll just go and look at the segment real quick. So, I mean, that's kind of my quick and dirty assessment of it, because when I can get the rib mobs, I get a sense how every unit is moving. And once I get a restriction, I go in to see, okay, is it the rib, or is it actually the facet joint, or translation? So that may be something to do too with her as you go through, just having her laying it over. Just think of your thumb as a very specific foam roller. Protect your hands so your thumb lasts the next 20 years.
Right.
But that may be a good thing too, because it also kind of get in that extension moment or extension side bending moment over your hand. I think it's a bit of proprioceptive input when everything's moving well. Yeah. And it's segmentally, thing where that's where I'll get them to kind of get a sense of I can extend over this one segment where I'm restricted, especially if you're in upper cervical spine, upper thoracic spine. So that's just another technique I would probably play with her being 32. She should have a fairly mobile spine.
Mm-hmm.
Did you say what her cervical pivums and pavums were?
Yeah, pretty normal. Like a little stiffness early on, more like lower cervical spine. We worked on that early, and that's been pretty good since. I will check it every now and then, especially when she is reporting like increased, paresthesia during the day or something like that, but not significant from what I found. So that's screaming like a segmental problem or anything like that.
Yeah. I was just thinking, she's been so stiff in her thoracic spine for so long, just making sure that she's not ending up wearing out any joints, or that if she ends up getting like hypermobile, because that could facilitate a joint too.
Yeah, absolutely. I think her age is helping her out at this point. Fast forward a few years, we might be finding that problem. So I'm glad she's doing this now.
Is she doing like self-thoracic extension?
Oh yeah, she was doing that for years
sessions?
Before even coming to talk to me. She has the foam roller. She's starting to become a PTA, so she bought her own cupping set a while back. So she'll have her husband cup her like thoracic, paraspinals. All does well temporarily, but it hasn't caused any permanent changes yet. Early on, I gave her, basic mobility drills too through the thoracic spine. Again, temporary help, but it's the permanent changes which she was having trouble with before we started formally treating her.
So her primary complaint is then the irritation she gets when she's at work.
Yeah. Yep.
Okay.
And which is seated desk work all day, on the phone all day.
And again, is it primarily the hand or the shoulder region?
Mainly the hand and thoracic spine. Shoulders actually don't bother her too much.
Okay. What's your thoracic
headset? Oh, sorry.
No. Thoracic.
Hand and thoracic spine. Yeah.
What's your thoracic position in seated?
Pretty forward flexed for the most part. When I assess her in clinic, she knows to like get herself in, quote unquote good posture and everything. So that's why I kind of was interested by the double crush idea, where if it's more positional, and she's going to get her symptoms. So Friday, I'm going to play with that a bit to see if we can actually start to find that weakness and see if we can make some corrections that way and some modifications to her work setup and help out that way.
Yeah, that's what you're looking at. You could use lumbar roll. And again, I use a lumbar roll for the cervical spine and the lumbar spine. See if that can reset the head and neck position as well as shoulders. With that, you're looking at arm rest, non-arm rest, especially as people. I look to make sure it's okay. The achiness in the upper spine, which is more that overstretch, that hysteresis process of ligamentous stretching versus, okay, are the hands kind of intrinsic? Am I getting kind of compression of the nerve there?
Right. And that's why I was actually curious. She couldn't give me an answer, but if they found any like ligamentous injury from the incident when they did, and I can't remember if she actually ever did have an MRI or not, but did we actually get some ligamentous problems that are just really keeping her within the misery that she's in?
Yeah, that's what it is. The hypermobile ones are the worst ones, just because it's stability into that system. You get that stable long enough without them kind of gliding on it. That's where it's like seated position, at home on the couch position. I try to manage what I think like 360 degrees of the variables, from sleep position to sitting at work, to manage every one to get it all to cool down. So those hard to treat cases, or they're coming to me from another therapist, the first thing I'm thinking is I have to look at basically what is their body position at all times, because there's probably a driver in there somewhere that they didn't get better with kind of regular care as well. So with her, it's going to be her favorite sitting positions, studying if she's a PTA.
Mm-hmm.
And then look at the outflow to the hand.
Does she have a headset?
No, our region's in the process of trying to get those, and it's a little delayed right now.
Especially if she's like this half the day.
Yeah, absolutely. And I know she's at a busier clinic too. That's actually probably starting to ramp up a bit. So I know she's been extra busy with everything. That's good stuff. I got some good stuff for her. I appreciate that.
Have you tried, like when she does test kind of weak, have you wobbled her and retested right away?
Yeah. The thing is, she doesn't often test too wink, but we have played with some wobbles just for some of that proprioceptive input. I do think I'm leaning towards more like instability, just based on her response to like some of the vibration board stuff that she's had when she came in super flared up.
Yeah.
Because I do think it was just some good neuro input to ramp down some of the tone. And then she's obviously just weak. Scapular thoracic spine's very weak. She has trouble with quadruped stuff. So I think she's just got that muscular imbalance too that's driving a lot of this problem. Like if I have her in quadruped doing some like just weight shifting on her arms, if she goes too far into that right, she feels like it's going to buckle. It hasn't, but she definitely gets the weakness of it to the point where like I was thinking about adding some reaching with it too to kind of work on some unilateral stability, and we haven't been able to get to that quite yet.
Interesting. If you look at her overhead arm reach to see is she translating to the same side as she should, or is she shifting to the opposite side? She having a hard time finding.
Not so much, but that'll be pretty good to look at. I do know if I look at like bilateral flexion, she does tend to shear forward at thoracic spine quite a bit.
Yeah.
And we've been trying to work on correcting that too.
I go back and look at the seated AP test segmentally, just see if you can find one that gives her that feel, that one that moves.
Yeah.
If she is hypermobile in there somewhere, you should be able to you may find one that maybe not did show up the first time, but if you do just to be able to just change your angle a little bit on each one, maybe up or down, just to see, okay, is there one that just gives you a little bit more shear force? And good chance you're going to find one.
Right. Yeah. Good.
That's always good to know. Like I'll see one in Justin, like you'll get one from kettlebell swings every now and then. I get pissed off because you got that segment which will shear. It's hypermobile, and again, he's good until he's not good.
Right. Awesome.
Oh, I have some news about my really terrible disc herniation guy.
Mm-hmm. Oh yeah.
So he got an injection last week on Wednesday. He saw the pain doctor, and when the original doctor got a hold of me with the MRI results, they made it sound like 2-3 was the worst herniated disc into an extrusion. But the pain doctor said that he thinks 2-3 is just a red herring, and that 4-5 is his real problem, which makes sense with his weakness pattern, and his glutes were really facilitated. But I was thinking maybe it was just a little bit more of a central disc at 2-3, picking off those fibers. But he got injected at 4-5 instead, and is doing, I think, considerably better with baseline calf pain at 1.
Good.
Now, yeah, and he started gabapentin. He got his first 9-hour night of sleep last night. So it's just so interesting to see how big of a difference even just his general personality is when he's not in terrible pain. He was so polite and nice when he was in pain, but now that he's not in pain, you can really tell that he's feeling a lot better.
Good.
But the pain doc emailed me back and he said, he was in really rough shape, and they actually scheduled the second one automatically because I think he looked so bad. So we're trying to figure out if I think he's going to go back on the 12th, so it's 2 weeks from today, for another one. And I needled glute max and L4 through S1 multiply on that left side today. So hopefully that will help too. He's never been like, I guess I always put emphasis needling on muscles that are hypertonic and tender.
Mm-hmm.
And he's been hypertonic there, but like no tenderness, which I just find also to be like very interesting, which is why I haven't also put a ton of emphasis on needling there, because you know, if they're providing stability or, you know, latent trigger points, but I'll be curious to see.
You needle muscle that's hypotonic. You needle muscle that's hypertonic. It's really about facilitating input.
Yeah,
so
that's true.
I know it's L4, L5 region. You know, based out carpet bomb, I'll go from maybe 2 down to 5, maybe even do sacral multifidi. What you're doing is you're trying to affect the central nervous system to downregulate the pain system, be it central or peripheral. So.
His press-ups were less painful at the top of the range after needling him, because usually at the end range of a press-up, he'd get some kind of pain in L5S1 or kind of like PSIS area. You know, he still can't extend his knee in late swing.
Okay.
Like right before, like he still actually got like enough neural tension that he's not walking normally yet. You know, do you think any like nerve glides would actually help him?
Probably not.
Or would they just be like irritating?
I think it'd be an anti. I don't know that it would, you know, some of those things I would if you think I want to try it, I would do it. Because I don't think it's contributing. But neural sensitivity, then I doubt that would really, what you look at then is, can I desensitize the nerve again? Does the nerve glide desensitize the system? Just kind of an anti in it. My guess is weight bearing load and amount of tension through the system, that's gonna be a much stronger pull than, you know, a passive nerve glide would release. But I wouldn't say no reason not to play with it.
I mean, he was feeling well enough today. We did some like thoracic opening, pec stretches, just like abdominal and lower body isometrics, because he's like, I'm dying to sweat a little. I'm like, sorry man, I can't lift weights. Like, you know, he's like, I just feel really gross. I'm like, well, you're gonna feel worse if you know, try to go do jumping jacks right now. And I think I mentioned he's got Optum, which I don't know if you guys ever do.
It's a pain.
I spent 40 minutes on the phone with the notorious woman in our region yesterday. I think she's in our region. Maybe she's not. Maybe she handled a lot, but she's the worst. He got 8 visits and then 4, and this was, I think, his 3rd visit.
Yeah, you get 2 next time.
Yeah, and I am like really worried, and I guess I'm kind of curious what your assessment would be for, you know, if I have 3 visits left with him before he goes self-pay, and we know he has another injection scheduled for 2 weeks from today, even though he's like, do I need to go even if I'm feeling a lot better? I'm like, you still can't really walk. So like, I mean, I'm glad you feel better, but don't let this, like, you're not really better yet.
Yeah, you're not ready to load.
Yeah.
He's not ready to do what he wants to do.
Yeah.
I would try to get as much information as you can from the pain guy on it too, and the injections, because that's kind of a thing too, that, hey, he's got injections, he's getting better. You know, this is my plan to get. You've seen him twice a week?
I have been. I saw him once last week. I saw him on Monday. He got an injection on Wednesday last week, and then Dr. Walega didn't, he said he usually wants 5 to 7 days before they start back in PT.
Okay. So that's good. I advise you a few more visits in time, but that's what you want to do, is just say, listen, you know, we just need you want to try and get another 4 visits at least. And that gives you another 2 weeks, you know, out from there when it comes back around again. But the thing in your favor is he's gotten a back injection. He's doing much better. This is what he can do. It's just spelling out, okay, he can't extend his knee and walk on his leg or load the leg completely yet.
Yeah.
You know, record where he's weak, but also record the column of he's 50% better.
Yeah.
You know, in this week span.
Oh, since the last
Yeah, since the
Oh,
last
since the injection.
ride the wave of the injections and how long that can take you to say, okay, he's getting better. This is what we want to do before we discharge him.
You mean that would help in our case for Optum?
More visits, yeah.
Yeah. I mean, I got so frustrated yesterday because yesterday I was like arguing about a different patient who can't sit, and they're like, well, sitting is self-limiting, so it's not really a functional task. And I'm like, are you serious? They denied an eval. And I'm like,
It's funny, you're bigger, so Optum looks at you closer. Like we're smaller, and like our visits per incident rate is pretty low. So we're like the top tier status with Optum. So we don't have to go through because you're a big organization, the wide variety of therapists. They look at our numbers and say, well, you're getting people out in 7 visits. So we don't have to ask for authorization as much. We have to get pretty far down the line before they'll start questioning us and calling us on things. So it is nice in that sense. But the first 2-3 years we were here, it was a pain in the ass. They did the exact same thing.
Yeah. Okay. So would you continue to see him twice a week? Or I guess if I could see him twice next week, and then Monday the following week, and his injection would be on Wednesday, that could theoretically chew up all the visits they give us.
Yeah, what you want to try and do is get another month's worth of visits, even if it's 1 time a week. Because he's doing better, and then if you can get a home program for him, just to progress him. So if you get another 4 visits, then you can try and stretch those visits out.
Yeah. So I guess we should probably reeval him on Monday. Wait, if we get 4 visits, just see him once a week. We should probably decrease to once a week anyway.
Yeah.
I mean, we do offer, I think you know this, but if he feels like needling is really helpful, we offer that in a fee-for-service capacity, where I don't know if we have to like report that to them necessarily, because what I've heard is if you have a 30-day hiatus, then they're more likely to approve more visits after that. So they'll deny, make you wait 30 days, and if you're still in pain, then you can get more visits. But I don't know if we have to report that we've seen him in that time on a fee-for-service basis.
Yeah. That I don't know.
Probably just don't ask.
It depends how much they audit. Just resubmitting the case as a case, then they may just go through the system.
Yeah. Well, and my first code was acute low back pain without sciatica. And since then it has peripheralized. So I wonder if when I do a reeval, maybe that would carry a little bit more weight if, as long as it doesn't make them look like I made them worse. So,
it's challenging. Optum's challenging that way. Because this guy can
it's just, and that's kind of why I don't usually argue too much unnecessarily with them. When people are really good and I get 2 visits, I'm like, okay, I can discharge them, with no problem in that amount of time. But it's cases like these where I want to like hang on to my clout.
Yeah.
And then, try to do that. But we have a lady who just is so condescending. She's like, I've been a physical therapist for 35 years.
Yeah, no, I was less ever treated a patient in a meaningful capacity.
I know. I don't want to be like, you so condescending. Anyway. Cool. Do you have more time, or you gotta go?
We gotta get going soon. Got something else?
I can save it for next week.
Okay.
But I'm really excited. I'm glad that we talked about that shoulder patient. So. No,
it's always helpful. I mean, what's good about it is you always kind of have a good spin on the cases. You put it out there with a lot of detail, and they've been good to discuss. Like today was good.
Yeah, it was really helpful, and I took a lot of notes. So, I think I will have seen her. I'll see her at least twice before next week, so I'll be able to report back. So, Great.
Great. Yep. Take care.
Have a good day.